Hello everyone, good evening. Continuing with our cancer series in general surgery, today is the last class of that series, that is Cancers in Surgery 5. And today we will cover cancers that are going to be oral cavity malignancies and salivary gland tumors. All of them are important both for undergraduates as well as NEET PG. We will try to cover as much as possible of the important points in these cancers. Alright, so I hope you guys can see me and hear me. Quite a few of you are already online. Please give a thumbs up so I know you guys are with me. I can see your messages in the YouTube chat box. Great. Okay. Right. So as people are joining in, let me tell you about the Unacademy platform. So I am Dr. Amrit Nasta. I am the surgery educator on the Unacademy platform. I am a bariatric surgeon from Mumbai. Please download the Unacademy Learning app where you can follow me, follow my profile so you'll get regular updates of the classes that I am going to be conducting, as well as get information about a lot of educators who are on the platform and their relevant subjects. Those of you appearing for NEET PG 2021 in April, there is going to be an intensive revision batch which is going to start tomorrow. So if you wish to learn from a lot of amazing educators in short time and cover your syllabus for the April NEET PG, do join in, do take the subscription. Please use my referral code 10 surgery. I think a 3-month subscription for this exam is going to be enough. And next Sunday there is going to be an Academy combat quiz, which is going to be based on second year subjects. So a lot of amazing prizes in that quiz if you wish to apply. That quiz is free of charge. You don't have to pay anything. You can just log in, register yourself, and then you can give the quiz next Sunday at 5 p.m. Alright. Okay, so before I begin the class, I'll just tell you of how it is going to be conducted. It is going to be an MCQ pattern class, and we will try to discuss as much relevant theory as possible of these topics. So we will start with oral malignancies, and then we'll go to salivary gland tumors. जितना possible होगा उतना cover करेंगे आज. In the upcoming week, I am going to take classes on image-based questions as well as cancers and hepatobiliary surgery on YouTube. So do join me for those classes. I will be sharing the links as they get published. Okay, fine. So let's begin the class. Let's begin with something easy, something that we believe we know, but trust me, a lot of us don't. Which is the most common site overall of malignancy in the oral cavity? Most common site overall for malignancy in the oral cavity. Is it tongue, lip, buccal mucosa, or floor of the mouth? This question that I am putting is from Bailey. So this is not specific to India. Okay, this is overall worldwide most common site of oral malignancy. Of course, in India it's going to be a different answer, but if you get an MCQ, they are not going to ask you India. If they ask you India, then you go by what the PSM books say, because PSM books give a different answer and Bailey gives a different answer. So Bailey gives you overall worldwide distribution. Is it tongue, lip, buccal mucosa, or floor of the mouth? Okay, Akanksha says tongue. Interesting. Nobody for buccal mucosa? Okay, unfortunately no. Answer is floor of the mouth. Answer is floor of the mouth. This is directly from Bailey. So first things first, what is oral cavity? What do we label as oral cavity? We need to know the boundaries. Anteriorly, the boundary of oral cavity is the outer border of the lips, which is also called as the vermilion border. So please understand, lips are a part of oral cavity. The outer border of the lips, that is your vermilion border. Okay, that is where the oral cavity starts. Then you have the lips, you have the buccal mucosa, tongue, floor of mouth, gingiva buccal sulcus, gingiva, hard palate. Superiorly, the junction of hard palate and soft palate, which means only the hard palate is in the oral cavity. The soft palate is not. The soft palate, mind you, is not a part of oral cavity. What is it a part of? Soft palate, so where the hard palate ends and the soft palate begins, that is the upper limit. So soft palate is what then, if it's not oral cavity? You must know this because this is how they will trick you in the MCQs. So soft palate is not oral cavity. Soft palate is oropharynx. Okay, so hard palate is counted. Soft palate is not. Then tongue, only the anterior two-thirds is counted in oral cavity. The posterior one-third of tongue, base of the tongue, all of that will again be counted in oropharynx. Lateral boundary is retromolar trigon. So the lateral boundary is retromolar trigon. Let us be very clear on this. All this comprises the oral cavity. इसके पीछे जो कुछ भी आएगा. So anything behind the retromolar trigon. Retromolar trigon is the space on the gums, on the alveolar margin behind the last molar tooth. That is called the retromolar trigon. उसके पीछे again becomes oropharynx. Alright, we need to know this differentiation because they behave differently, their metastasis is different, oral cavity and oropharynx. So that is your boundary. This is the line I have taken directly from Bailey. Common sites. ये Bailey से line ली है. The first word given is floor of the mouth. This is worldwide, floor of the mouth. Then gingivobuccal sulcus, which in PSM books is called as the most common site in India. Then they say tongue, lip and other parts. So if they ask you overall, it's tricky, but I would say go for floor of the mouth because that is what Bailey gives you, especially if this is there in the option. क्योंकि एग्जामिनर ने ऑप्शन सोच के डाला होगा, ऐसे ही वही ऑप्शन नहीं डालेगा. Okay, most common cancer, squamous cell carcinoma, which we discussed earlier. Squamous cell carcinoma, of course. Oral cavity is lined by stratified squamous non-keratinized epithelium. Stratified squamous non-keratinized epithelium, non-keratinized. Okay, keratin is seen on the skin epithelium. This is going to be non-keratinized epithelium. Okay, this is again directly from Bailey. So first we look at the oral cavity anatomy, oral cancers, then we look at the risk factors. Let's take it like a long answer question on oral malignancy. So oral cancers have risk factors and they have pre-malignant lesions or precursor lesions. Which of these has the highest malignant potential? Leukoplakia, speckled leukoplakia, erythroplakia, or oral submucous fibrosis. So again in Bailey, there is a table which classifies precursor lesions as high risk, medium risk, and low risk. Directly मैंने उधर से ही लिया है. High risk, medium risk, and low risk. So I've gotten some answers as speckled leukoplakia. Is that so? Is it speckled leukoplakia? Or is it erythroplakia? Or is it leukoplakia per se? And we need to know what all of these stand for. And let me tell you, I will make your life easy. Oral submucous fibrosis is counted in medium risk. All these three are counted in high risk. Leukoplakia, speckled leukoplakia, and erythroplakia are all counted in high risk. Which has the highest risk? According to Bailey and Love, the answer is speckled leukoplakia. Between leuko and erythroplakia is 20 times more. 20 times more. But overall, the answer is speckled. Speckled means what? It's not a clear white patch. It is an irregular white patch. So it is white and red mixed. It's probably a mixture of these two. Hence speckled. Means it is most metabolically active. That is why it has the highest malignancy potential. So high risk are all these three. Highest risk according to Bailey is speckled leukoplakia. Alright, now we need to know all of this. What is leukoplakia? What is erythroplakia? Leukoplakia, we know it's a white patch in the oral cavity, anywhere in the oral cavity. Can't be rubbed off, can't be characterized pathologically. What does that mean? Can't be characterized pathologically. I'll show you a picture. This white patch that you see, lower border of the tongue, this one, this is leukoplakia. There are many reasons for leukoplakia. Of course, there has to be some insult to the oral mucosa that will give you leukoplakia. What does it mean, not characterized pathologically? If I take a biopsy, what will I get in the pathology? Yeah, this is not there in many books. This I had to read a lot online to get the answer to this question. If I take a biopsy of leukoplakia, what do I get? I mean, we call it cannot be characterized pathologically, that's fine. But if I take a biopsy, what do I see? Do I see tongue epithelium? I will see something, right? What is that something? What do I see here? Mitotic figures. Interesting. If I see mitotic figures which are abnormal, then I can characterize it, no? Then how is it not characterizable if I'm seeing mitotic figures? So no, that's not correct. I must see something. I cannot say no, this is just normal tongue epithelium, right? तो कुछ तो दिखना चाहिए. तो क्या दिखेगा? So what I see in this biopsy is called hyperkeratosis. Hyperkeratosis. Alright, that is the hallmark. I mean, hyperkeratosis means nothing. Okay, it means nothing. There is nothing significant when I say hyperkeratosis. But remember, your oral mucosa should not, it is non-keratinized. So if I see keratosis, it is pathological. But it can't be characterized pathologically. This is the meaning of the term cannot be characterized. If this epithelium undergoes dysplasia, then I know it is a true precursor lesion. So dysplasia can be seen. But dysplasia is not a feature of leukoplakia. It is when leukoplakia undergoes dysplasia that I say now it is turning to malignancy. It's like Barrett's esophagus. Barrett's is what? Columnar epithelium or columnar metaplasia. Same thing over here. Hyperkeratosis. That's why Barrett's can be characterized. This cannot be characterized. This what you see here. There are white patches and there are red patches both. This is speckled leukoplakia. Speckled leukoplakia means there is a mixture of both. Leukoplakia bhi hai, erythroplakia bhi hai. So both of them, leuco and erythro, this is white patch, this is red patch, this is red velvety, can't be characterized, can't be rubbed off. This is important because leukoplakia looks a lot like candidiasis. So in the exam they commonly ask, the white patch that you see in the oral mucosa, how do you know it is not candidiasis? You say can't be rubbed off. And the fourth is chronic hyperplastic candidiasis. These are the four high risk pre-malignant lesions. Medium risk submucous fibrosis, low risk lichen planus, discoid lupus. ये सारा बेली से लिया है मैंने. But once we get the gist of the high risk, way important. Does HPV, can you say HPV is a risk factor for oral cancer? Is HPV a risk factor for oral cancer? Yeah. Yes. Nurel says yes, because now there is a new TNM staging. Like we discussed new TNM for thyroid. Similarly, there is a new TNM for oral cancers also. So they differentiate oral cancers which are HPV associated and non-HPV associated. So is there a difference between oral HPV related cancers and HPV unrelated? Okay, first things first, HPV is not a risk factor for oral cancers. Let's be very clear on that. HPV now has been considered as a risk factor only for oropharyngeal cancers. Oropharyngeal. Now you know what is oropharyngeal. Soft palate, posterior third of the tongue, tonsillar pillars, retromolar trigone के पीछे. All those areas are oropharynx. HPV affects those areas. Oral cancers per se, according to the new TNM, is not dependent on HPV or not, because they say HPV does not really cause oral cancer, it causes more posterior cancers. Okay, we will discuss the staging again, don't worry about it. Now the spread of tumors. and the MSKCC level of nodes. What does level 2A node represent? ये तो बहुत ही important है, ये तो सारे एग्जाम में पूछते हैं. What does level 2A in MSKCC represent? Neck nodes. Submandibular group, above angle of mandible and anterior to 11th nerve, above hyoid and anterior to 11th nerve, or above hyoid and posterior to 11th nerve. Which of these is level 2A? First you need to know what is level 2, then go one step ahead and go to level 2A. I hope you heard MSKCC. Your neck nodes 1, 2, 3, 4, 5, 6, 7, they are all MSKCC classification. Memorial Sloan Kettering Cancer Center. एक ही है ये. It's a very famous institute where they do a lot of oncosurgery work. They have devised the staging of neck nodes because earlier there was a very weird staging. There was an internal Waldeer's ring, external Waldeer's ring, jugulo-digastric, jugulo-omohyoid, preauricular, ऐसे अलग-अलग थे. They classified all as one because these are the nodes which are important in oral and oropharyngeal cancers or head and neck cancers. So they simplified it. They said 1 is this, 2 is this, 3, 4, 5 ऐसे simplify कर दिया. So what is 2A? What does that represent? सब लोग अलग अलग आंसर दे रहे हैं आज, क्या हो गया? It's such difficult question? Definitely not. Okay. Submandibular is below the angle of mandible. It's between the digastric levels, between the digastric nodes. That is your submandibular. This is your mandible. I'll show you in the picture. Submandibular group is 1B. Okay. Submandibular is 1B. There is nothing above the angle of mandible. ऐसा तो कोई है ही नहीं. There is no level above the angle of mandible. Your doubt should have only been between C and D. So 2A is anterior. Answer is C. 2B is posterior to the 11th nerve. I'll show you how it looks. Okay, we need to know this. So 1A and 1B, that is the first one. This is your anterior belly of digastric. So your digastric starts from the mentum and goes to the hyoid bone. This is your hyoid bone. Right. So your anterior belly of digastric goes from the mentum to the hyoid bone. This is your anterior belly. And from the hyoid, it goes to the mastoid like this. This is your anterior belly of digastric. This is your posterior belly of digastric. Anterior and posterior belly के बीच में is your 1B. That is your submandibular. Anterior के नीचे, between the two anterior bellies of digastric is 1A, submental. So 1A, 1B, submental, submandibular. 2, 3 and 4, these are called your deep cervical nodes. Right, they are your deep cervical nodes. They are all along the anterior border of sternomastoid. So ये मेरी sternomastoid है, उसके anterior border पे. But where do I divide 2, 3 and 4? What is the division? The division, you just need to remember hyoid bone and cricoid cartilage. Hyoid bone and cricoid cartilage. Whatever is along SCM but above the hyoid, that will be level 2. Whatever is between hyoid and cricoid will be level 3. That means this level. Whatever is below cricoid will be level 4. That's how you will clinically identify 2, 3 and 4. So this is my level 2. Anterior above the hyoid. Level 3 will be between hyoid and cricoid. And level 4 will be subcricoid. ये तो पता चल गया. So you know your level 2 is going to be above hyoid in this area. Now 2 has been divided into 2A and 2B. That was the question. 2A is anterior to the spinal accessory nerve. तो ऐसे ये nerve जाती है spinal accessory nerve इधर से ऐसे. जो ये nerve के anterior है, that is 2A. जो इसके पीछे है, that is 2B. So spinal accessory nerve divides 2A and 2B. Similarly, there is a 5A and 5B also. Now 5 is posterior triangle. Posterior triangle यानी SCM के पीछे, this area. Behind the SCM, in front of trapezius. This is your posterior triangle. 5A is above the cricoid, 5B is below the cricoid. इसी में मेरा supraclavicular आता है. So next MCQ will be supraclavicular node, that is 5B. Then your level 6 is your anterior or central compartment, and level 7 is mediastinal, but mediastinal are not clinically palpable. Rule of the thumb, golden rule. Oral cancers. You know what are oral cancers now? Lip, tongue, buccal mucosa, floor of the mouth. Oral cancers normally will metastasize the first to level 1A or 1B or 2. Okay, these are the initial nodes that are going to be involved in oral cancers. Then from 1A, 1B or 2, they will go to 3, then they'll go to 4, maybe go to 5. ज़्यादा से ज़्यादा यहाँ तक जाएंगे, ज़्यादा से ज़्यादा 6 तक नॉर्मली ओरल कैंसर्स नहीं जाते. 4B, 5, 6 ये जो वाले नोड्स हैं नीचे वाले, they get metastasis from aerodigestive cancers, larynx, thyroid, remember thyroid level 6, Delphian node, upper esophagus, they all go to these nodes. So oral, oropharyngeal, they go to these usually. And upper aerodigestive tract, they go to these, the lower ones. Skip metastasis means it will jump a station. That is skip metastasis, where it jumps a station. So maybe you will get in 1B, you will get in 2A, and you will get level 4 involved, and level 3 will be skipped. Normally ऐसा होता नहीं है. Okay, normally skip metastasis hota nahi hai. It's just that level 3 are not very clinically evident, so we don't come to know. Which is why if 2 and 4 are involved, I assume 3 is also involved, which means I will remove all of these nodes. I am not going to keep this inside and only remove 2 and 4. पहले के ज़माने में करते थे. It used to be called cherry picking. In thyroid, it used to be called berry picking. Thyroid में उसको बोलते थे berry picking. Just remove the involved nodes, but that's wrong. You have to remove the entire group of nodes. All right. Okay, this is what I want to stress a little bit on. This is important. This is what has to be stressed. Which of these is the incorrect component of TNM staging of oral malignancy? This is new TNM. Okay, और AJCC8. जैसे हमने थायराइड का डिस्कस किया वैसे ओरल मैलिग्नेंसी का. AJCC8, which is the incorrect component. Separate staging based on etiology. Extracapsular spread is responsible for upstaging end status. Tumor of size 3 centimeters, depth of invasion 11 millimeters is T2. Bilateral lymph node implies N to C. Because the entire treatment is based on what is going to be the TNM status. So what is incorrect? Is there a separate staging based on etiology? Yes, there is. So there is HPV associated and non-HPV, but mind you, this is for oropharyngeal. This is for oropharyngeal. It's not for oral. Extracapsular spread is responsible for upstaging end status. Yes, absolutely correct. This is true. In older TNM, ये कोई फंडा था ही नहीं extracapsular spread. Either the lymph nodes were involved or not involved. If the spread is outside the capsule of the node, the end status gets upstaged. I'll show you how. Bilateral lymph node implies N to C. This is correct. Tumor of size 3 centimeters. Depth of invasion 11 millimeters. Is this T2? Is this T2? Or is it T3? Or is it T4? Very, very, very important point. Come on. Is this T2? Or T3 or T4 or T1? We did thyroid का staging. वैसा ही है, काफी similar है. तभी मैंने बोला था oral cancer का staging ऐसा ही है. Very similar. Papillary और follicular का जैसा था. If the depth is more than 10 millimeters, It is T3. Okay, this is something newly added. This is new TNM. So this is the answer. Okay, more than 10 millimeters is T3. Look at the staging, extremely important. थायराइड का ऐसा ही था, ज्यादा ज्यादा फर्क नहीं था. थायराइड वाज वेरी सिमिलर. आई विल शो यू द कोरिलेट. T1 less than or equal to 2, T2 2 to 4, T3 more than 4, same as thyroid. Thyroid में T3 में extra था strap muscles involvement, that was extra. T4A 4B was resectable and unresectable surrounding structures there also. So this part is the same as thyroid. This is what is newly added. If the depth of invasion is between 5 to 10 millimeters, it goes in T2, irrespective of size. Obviously, size has to be up to 4 centimeters. If size is more than 4 centimeters, automatically T3 में जाएगा. But up to 4 centimeters, if the depth of invasion is between 5 to 10 millimeters, it goes in T2. More than 10 millimeters, it goes in T3. So this question, 3 centimeters technically should go in T2 because it's 2 to 4. But DOI is more than 10 millimeters. So DOI more than 10 millimeters, T3. This is what we need to know. This is the only way they are going to fool you. They will only fool you based on depth of invasion क्योंकि इसे newly add किया है. Okay, yeah, they have added newly, and they don't expect everybody to know. Not all the new MCQ books have it. Many of us use old MCQ book जो senior ने दिया है 1 साल 2 साल पुरानी, उसमें तो अपडेट नहीं हुआ होगा. This is where students miss out. Okay, सीनियर की बुक से, या अगर ऐप में अपलोड नहीं किया है, या अगर सर्जन ने बेली नहीं पढ़ी है जो पढ़ा रहा है तुमको, क्योंकि ये बेली में है. बेली में क्लियरली नहीं है. ओके, बेली में सिर्फ मेंशन है न्यू टीएनएम अकाउंट्स फॉर etiology एंड डेप्थ ऑफ इन्वेजन. दिस इज मेंशन, बट दिस इज नॉट मेंशन. This is there only online. So if the person who has made the MCQ book has only made it from Bailey and Saveston, where they have not updated, you will not know. But if it comes in the MCQ, and the examiner who has set the paper knows, especially if he is a head and neck surgeon, वो तो पक्का ये डालेगा. जैसे मैंने तुमको घुमाया, same way ऐसे ही करेगा. So depth of invasion is new. Whichever is higher, that gets counted. Size more than 4 centimeter becomes T3, or depth of invasion more than 10 millimeters becomes T3. Both become T3. This is what we need to know. Baki N, they have not changed. N, it's the same. Single 3 centimeters, single 3 to 6 centimeters is 2A, or multiple up to 6 centimeters, or bilateral up to 6 centimeters is N2. Normally in cancers we don't say bilateral lymph node metastasis. Like in breast, if the tumor was in the right breast and there was a left side axillary node, it would be called M1. So contralateral is usually M1, not in oral cancers, because oral cancers are known to have bilateral metastasis, especially central oral cancers. Lip हो, tongue हो, floor of the mouth हो, वो तो दोनों तरफ जा सकते हैं. So for oral cancers, bilateral remains N2. N3 more than 6 centimeters or extracapsular spread. Whether it is any size, extracapsular spread with any size and number. Because they say if the tumor has spread outside the capsule of the lymph node, it becomes locally advanced. Okay, it becomes locally advanced. That's why extracapsular spread is special mention. You need to focus on these points. In this staging, it's same like thyroid. You need to focus only on 3 points: depth of invasion, bilateral, and extracapsular spread. And no, they are correlates. बस इसी पे क्वेश्चन आएगा, और कोई तरीके से ट्विस्ट नहीं करेंगे. Are we clear on this? Please take some time to digest these things, because till you don't digest these things, easy questions में भी हम गड़बड़ करेंगे. And in the exam you will spend 2-3 minutes on that question and then you will be stuck, and then such easy questions you will make a mess. For diagnostic purposes, what is the imaging modality of choice? Again from Bailey. This is directly from Bailey. Yes, I do biopsy, but if I want to image, if I want to see where the tumor is, what is the depth of invasion, is it getting advanced, what is the modality of choice? Is it USG, CT, MR, PET scan? बड़ा बेसिक सा सवाल है इसमें flaw in this answer and you are gone. Yes, USG, CT, MR, PET CT. Be bold, be brave, you can say something. Even if you're not very confident, it's okay, nobody is going to judge you. Those who are not answering but imagining that they know the answer, they will not be able to answer in the exam. That false satisfaction should not go with us. Okay, Nurel says PET CT. PET CT is for staging. Okay, never for diagnosis. PET CT is for staging. Answer is MRI. MRI is the investigation of choice for soft tissue tumors. If I want to look for bony invasion, bony invasion, you know, oral cancers, they tend to involve the mandible, maxilla. What is the investigation of choice? Bony invasion. Like let's say the person says his teeth are falling. You feel maybe the tumor is involving the bony maxilla, the alveolar margin. You're not very sure. Bony invasion के लिए मैं कौन सा investigation करूँगा? Nural says OPG. No, OPG is not correct. I am asking you investigation of choice. I am not asking you overall. OPG करते भी नहीं है आजकल. कोई क्यों ही करेगा? It's such a basic investigation. OPG is just an X-ray of the teeth. So if I am looking for bony invasion, investigation of choice will be CECT. Very good. If they specify medullary invasion, not bony invasion, medullary invasion, if they specify the tumor has involved the medulla of the mandible, then again answer will be MRI. If they ask you lymph node metastasis, what will be the answer? Neck nodes, involvement of neck nodes, again answer will be CECT. 100 बात की एक बात, सिर्फ ट्यूमर देखना है, MRI करोगे, बोनी मेटास्टेसिस देखना है, CT करोगे, लिम्फ नोड करना है, CT करोगे, which means सारे पेशेंट्स में more or less you will do MRI plus CT or you will do MRI plus PET CT. MRI तो करने ही वाले हो. Then either you do CECT or you do PET CT. Got the gist of it? Any confusion? USG is only done for tongue. अगर टंग ट्यूमर है तो मैं यूएसजी करूंगा, बाकी ट्यूमर्स के लिए यूएसजी नहीं करूंगा. ओके, बकल म्यूकोजा में यूएसजी नहीं होता. करने को कुछ भी कर सकते हैं पर आंसर मत देना है. सो फॉर साइज नंबर कैरेक्टर MRI, फॉर मेटास्टेसिस आइदर CECT और PET CT. बोथ आर ओके. When I take a biopsy, so let's say the person has a growth on the tongue like this. We always say take a wedge biopsy. Why do we take wedge biopsy? Wedge biopsy means at the border with surrounding normal tissue. ऐसे. Why wedge biopsy? Why can't I take a core biopsy? Why do I have to take wedge biopsy? Wedge means I take edge of the tumor and surrounding normal tissue. Can I take biopsy from the center instead of taking from the wedge? Edge has least necrotic tissue. So then I should take edge biopsy. Just take from the edge. Why go outside? And for comparison with healthy tissue. Very good. So there are two reasons. First reason is the edge has maximum proliferation. The tumor is growing outwards. Understand? So the maximum activity, maximum proliferation will be at the edge. So wedge biopsy. Other is it helps the pathologist to compare with normal tissue. It helps them compare with normal tissue. That is why wedge biopsy. If there are neck nodes, I do FNAC. I told you about the imaging for metastasis, I can do PET scan. Okay, this is important. I have discussed this question earlier in one of my classes. अभी मैंने थोड़ा change किया है इसको. So whoever has attended earlier, I have twisted it a bit. So there is a buccal squamous cell carcinoma, 3 centimeters. There are no obvious neck nodes, without obvious neck nodes. So when I do the clinical examination, I can't feel any node. But I do MRI, I see a few ipsilateral level 2 nodes. PET scan otherwise is normal. There are no distant metastases. I decide to go with surgery. What surgery am I going to do? It's a very classical question. ये question बहुत लोगों को नहीं आएगा. But if you know the fundamentals, if you know the concepts, आराम से आएगा. Just have to know the fundamentals. Buccal SCC, yeah? There is a reason I have said buccal. Even head and neck onco surgeons don't have clarity. So they may give different answers. What I am going to teach you is what is textbook answer. What answer you will give in the exam. Textbook answer. Yes. First you have to think, there are no obvious nodes on clinical exam. Do I need a neck node excision? Everything is wide excision only. The contention is lymph node excision. Yes or no? If yes, level 2 only. Or ipsilateral MRND or bilateral MRND. करूँ तो करूँ क्या? कौन से नोड निकालूं या निकालूं ही नहीं? या बताओ. Do I need to remove the nodes? And if I remove the nodes, which one should I remove? एक तो चीज है, if I have decided to operate, the operation will always be a wide excision with some margin depending on the size. 1 centimeter, 1.5 centimeter, I take some margin. वो तो निकालना ही है. Buccal mucosa means I have to take thick margin. Lymph nodes removed or not? First things first, clinically no nodes means nothing. If in imaging shows nodes, that means there is nodal spread. Nodal spread is there. If nodal spread is there without lymph node excision तो हो ही नहीं सकता. Lymph node तो निकालने ही पड़ेंगे. अगर level 2 है, okay, level 2 है, I cannot assume level 1 is not involved. Nor can I assume level 3 is not involved. Just because MRI is showing level 2. There is nothing like level 2 excision. ऐसा तो कुछ होता ही नहीं है. There are always grouped excisions. Your doubt should have only been between ipsilateral or bilateral. I'll give you a simple rule of thumb again. If they are talking about ipsilateral nodes, you will do ipsilateral MRND. If they mention bilateral nodes, bilateral MRND. बस इतना ही सोचो. Yes, you can say buccal mucosa is an ipsilateral cancer, you will do ipsilateral. If instead of buccal mucosa, if it was tongue or floor of mouth, where bilateral mets are there, you may have thought of bilateral MRND. It's contentious. Okay, there is no guarantee. I'll give you rule of thumb. जो साइड के नोड्स इन्वॉल्व है वो साइड के नोड्स निकाल दो. जो साइड पे कैंसर है वो साइड के नोड्स निकाल दो. Don't opt for bilateral MRND unless they have specified a reason to do it. Because MRND is a very morbid procedure. You don't unnecessarily remove MRND. It's a very morbid procedure. Don't jump to MRND. Okay, so most of the times your answer will be ipsilateral. जो साइड पे lymph node metastasis है वो साइड पे. Now how do we remember this? This is a table which I have made, which is inspired from Bailey. Okay, inspired from Bailey for MCQ purposes and for answering in the exams. Okay, it's not very exacting, but it is very acceptable to write in the exam. For pre-malignant lesions like leukoplakia, you do laser vaporization. ल्यूकोप्लेकिया में lymph node मत निकालना. Early tumors. Okay, early tumors, removal of nodes is not mandatory. If nodes are involved, only then you will remove. Okay, if nodes are not involved, you can choose to not remove the nodes also. So this is a safe answer to write, with or without MRND. Yes, if nodes are present, like the case that we did, then of course you will remove the nodes. If the tumor is bigger in size, little advanced, then you will always remove the nodes. इतना ही फर्क है. T1, T2 may remove the nodes. T3, T4A if it's operable, always remove the nodes. मैंने कहीं भी यूनिलैटरल या बायलैटरल नहीं लिखा है, कहीं भी मैंने यूनिलैटरल या बायलैटरल नहीं मेंशन किए. That depends on the anatomy of the tumor and what they are specified. If they say bilateral nodes are involved, only then go for bilateral MRND. Just because it's a floor of the mouth tumor, don't jump to bilateral MRND. Don't do that. Keep it simple. Early tumors, no nodes, no MRND. Early tumor with nodes, of course MRND. Advanced tumors, big tumors, of course MRND. Fine. Don't complicate these kind of questions. There is enough on your plate to complicate. You have enough subjects, enough topics, enough cancers, enough things in medicine, enough names in orthopedics. We saw so many names over yesterday and today. कितने सारे नाम हैं. ये pin, ये screw, ये plate, ये nail. There is enough. This fracture, Montegia fracture, Galeazzi fracture, Smith's fracture. Let us try to keep things simple. Okay? This is how you will approach treatment of oral malignancies. This is a very important question, a very basic question. इसको बहुत घुमा फिरा के पूछा है बहुत बार. All of these are usually removed in MRND except usually removed in MRND except submandibular salivary gland, level 5 nodes, parotid tail, pretracheal nodes. Yes. Neural says tail of parotid. Interesting. Anyone for pretracheal node? ये node होता है क्या ऐसा कुछ? Is there something like a pretracheal node? Do you think we will remove submandibular gland? कोई submandibular salivary gland ना, not salivary node. Salivary gland. Neural is saying tail of parotid. Okay, first let us understand what is MRND. Then I'll give you the answer. तब तक आप सोचना. Neck dissection started olden days, radical neck dissection. Okay, and we are assuming everything on one side. Huh? Everything you assume is on one side. Now in radical neck dissection, what was done? Radical neck dissection of Kreil. You must have heard of Kreil. Thyroid में भी है Kreil. Kreil's method. Radical neck dissection was remove all lymph nodes from lumbar 1 to 5. Remove all fibrofatty lymphatics in the neck. Plus remove submandibular salivary gland. तो salivary gland निकालनी है. Plus remove tail of parotid. But it's radical. Old surgeons, very aggressive oncosurgeons. Plus you are going to remove spinal accessory nerve, internal jugular vein, spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle. This was radical neck dissection. It sounds only radical. They said this is too morbid. Do little less. Do modified radical neck dissection. जैसे you had radical mastectomy where he removed the pec major muscle, removed the nodes, intercostal muscles, then you said no, too morbid, make it little less. Similarly over this, make it little less, modified neck dissection. So here what they said, do the same radical neck dissection minus preserve spinal accessory nerve, internal jugular vein, SCM muscle. So these three are preserved. ऑलराइट अभी मैंने वो ऑप्शन में दिया नहीं क्योंकि वो सबको मालूम है. Everybody knows those three structures are preserved. That's why I didn't give it. But yes, submandibular gland is removed. 1 to 5 सारे के सारे nodes are removed. Tail of parotid is also removed. Level 6, this is level 6 node, Delphian node. They are not removed here. Say preserved in MRND. ऐसे ही सवाल आएगा. Don't expect them to tell you one of the options is SCM muscle और spinal accessory nerve. वो नहीं देंगे वो ऑप्शन. सबको मालूम है कि तुमको पता है, तो वो तो नहीं देंगे. Any neck dissection where I preserve more than this. Any neck dissection where I preserve more than this. Any neck dissection which is short of MRND, less than MRND, is called selective neck dissection. Selective neck dissection. Anything where I remove less than MRND is called selective neck dissection. Like if I remove only level 6, वो तो MRND में आता भी नहीं है. This I do in thyroid surgery, papillary carcinoma. I remove only level 6 Delphian node, don't have to remove any other, only pretracheal prelaryngeal. That is called central compartment clearance. Right? That is called central compartment clearance. ऐसे अलग अलग टाइप के होते हैं. There is one where I remove only level 2, 3, 4. That is called posterior. No, not posterior. That is called so not 2, 3, 4. Sorry. There is one where I remove 1, 2, 3. Okay, level 1, 2, 3. That is called supra omohyoid neck dissection. Supra omohyoid neck dissection. ऐसे अलग अलग टाइप के. Normally they are not done. Normally for exam your answer will be MRND. Okay. आज के ज़माने में they do MRND. Selective neck dissection is done in very advanced oncosurgical places. Okay. Please identify this pathology, this swelling that you see over here. So that was about oral malignancies. Now we are moving one step ahead to salivary malignancies, salivary tumors, salivary diseases. We'll try to do as much as possible. At least little bit of parotid and submandibular gland we should do. What is this pathology? Is it a ranula, cystic hygroma, ectopic thyroid, circumvallate papilloma? What is this disease over here? I hope someone has seen this before. It's a very classical disease. What is the normal site of ranula? Where do you normally see ranula? So ranula is seen in the floor of the mouth. Tongue के नीचे, floor of mouth. Normal site of cystic hygroma. Cystic hygroma is seen in the neck. Posterior triangle. Where you had your level 5 nodes, that's where you normally get cystic hygroma. This is a ectopic thyroid or a lingual thyroid. Circumvallate papilloma करके कुछ होता नहीं. There is nothing like circumvallate papilloma. This is a ranula. Floor of the mouth. So a ranula is nothing but there is a gland in the floor of the mouth, that is your sublingual salivary gland. It has a duct that is called duct of Ravenius. एक नहीं होता, multiple होते हैं. Multiple ducts. Multiple ducts of Ravenius. So there is a gland over here which has multiple ducts which open in the floor of the mouth. If these ducts get blocked, okay, if these ducts get blocked, the gland starts becoming bigger and bigger and bigger and bigger. It explodes. Okay, it ruptures and it forms a cyst like this. This is a extravasation cyst. It is a extravasation. Please understand, it's not a retention cyst. It's an extravasation cyst. It has happened after the duct has gotten blocked and then proximally it has dilated, secretions have become static and then it has ruptured. All that you have on top is the mucosa. There is no cyst wall. There is just the mucosa of the floor of the mouth, which is why this cyst is brilliantly transilluminant. It shows brilliant transillumination because it has a very thin wall. Brilliant transillumination. How do I treat this cyst? Treatment is simple. I have to excise the cyst, but I also have to excise the sublingual salivary gland. तो वो ग्लैंड भी मुझे निकालना पड़ता है. दैट इज द ट्रीटमेंट ऑफ द सिस्ट. रिमूव द सिस्ट अलॉन्ग विद द ग्लैंड जिसका डक्ट ब्लॉक हुआ है और वो ग्लैंड जो रप्चर हुआ है. दैट हैज टू बी रिमूव्ड. रिमेंबर वी हैव टू सबलिंगुअल सलाइवरी ग्लैंड्स. एक लेफ्ट में एक राइट में. देयर आर टू. दे आर ऑल पेयर्ड. पैरोटिड, सबमैंडिबुलर, सबलिंगुअल. दे आर ऑल पेयर्ड ग्लैंड्स. ओके. Important. Meal time syndrome. Where do you see meal time syndrome? Is it seen in viral parotitis, cielodinitis, cielodinosis, or bone cyst? Acha, Vishaka is saying cielodinitis. Acha. What is this cielodinosis? Heard of it? What is this cielodinosis? Is there such a thing? And what is this Staphne bone cyst? Then I'll tell you what is mealtime syndrome. Okay, you guys are right. This is submandibular cielodinitis. So your submandibular salivary gland, if this is the tongue, this is the floor of the mouth. Okay, let's say this is the floor of the mouth. This is your tongue, goes like this. There is a muscle over here in the floor of the mouth. What is the name of this muscle in the floor of the mouth? Cielodinosis is like diverticulitis. No, it's not. Staphne is ectopic salivary tissue in mandible. Excellent, that's absolutely right. What is this muscle in the floor of the mouth? And इसके नीचे is my submandibular salivary gland. ऐसी होती है submandibular gland, like this. Okay, and then I have the jaw over here. Okay, the angle of mandible and the jaw and the chin. So this is my submandibular salivary gland. इसकी जो duct होती है वो ऐसे जाती है. It goes anti-gravity. What is the name of the duct of submandibular gland? Wharton duct. So this duct goes anti-gravity, goes upwards. This gland has a lot of thick secretions, which is why the duct gets blocked with calculi very commonly. Yes, this is mylohyoid muscle, absolutely right. So calculi are common in the submandibular salivary gland because the duct has to go anti-gravity in contrast to other glands, and the secretions are thick. That is called submandibular cielodinitis, like there is a stone in the duct. Mealtime syndrome is when he eats a meal, the duct goes and gets blocked by the stone partially. There is a partial blockage and the gland swells. It happens usually when he starts eating and persists for 1 to 2 hours. So the swelling of the gland persists for 1 to 2 hours. Gradually the secretions get drained because it's a partial block and the swelling reduces. It's a classical feature of cielodinitis. Staphne bone cyst, she said correctly, it is ectopic salivary gland. Ectopic salivary gland. It is normally seen in the mandible. Normally seen in the mandible. CL adenosis, not given in books. CL adenosis is non-inflammatory enlargement of the gland. There are many reasons for that, but it is non-inflammatory enlargement. It is usually seen in people who are alcoholics, people who have cirrhosis of liver, people who have diabetes. They have some syndromes, Sjogren syndrome, all those syndromes. It is non-inflammatory enlargement of the salivary gland. It can be one gland, it can be multiple glands, but it is non-inflammatory. That is CL adenosis. Okay. Identify the incorrect statement. Most common malignant tumor of parotid is mucoepidermoid. The retromandibular vein divides the parotid into superficial and deep lobes. Stenson's duct opens directly above second molar upper. Pseudopodia responsible for recurrence after enucleation. Important question. Very important question. I am asking you the incorrect statement. Is the most common malignant tumor of parotid mucoepidermoid cancer or is it something else? And does the retromandibular vein really divide the parotid? Interesting, interesting. So ऐसा जाता है मेरा parotid gland कान के आगे. उसके पीछे there is a deep lobe. This is a superficial lobe. There is a deep lobe पीछे. And the superficial and deep lobes are divided by a very important structure running in between. That is the facial nerve, which splits into the 5 branches. ऐसे 5 branch निकलते हैं facial nerve के. Also, it is divided into superficial and deep lobes by a vein, which runs in between. So, unfortunately, Akanksha, the retromandibular vein divides the parotid. This is correct. So, it's called faciovenous plane of Patty. Faciovenous. The facio here stands for facial. Okay, not fascia. This is facial. Faciovenous plane of Patty. So B is correct, unfortunately. Most common malignant tumor of parotid is mucoepidermoid. This is correct. Overall, most common tumor of parotid, of course, is pleomorphic adenoma. No doubt about it. Pseudopodia are responsible for recurrence after enucleation. Of course, this is correct. The whole world knows my pleomorphic adenoma has these extensions. Pseudopodia. If I just remove the gland, if I just remove the tumor, not do a wide excision or a superficial parotidectomy, there will be recurrence. Nobody thought about this. Stenson's duct opens directly above the second molar. Is this correct? It does not open directly above the second molar. It opens directly opposite to second molar. Opposite. So it's on the side of the lips or the side of the buccal mucosa. It's not on the gingiva. Okay, it's not on the gums. It opens on the lip side. So it is opposite to the crown of the upper second molar. Okay, that's how I change the question. वो दांत के ऊपर नहीं खुलती है, वो गम के साइड पे खुलती है, मीन्स वो लिप के साइड पे खुलती है, एंटीरियर एस्पेक्ट. So it is opposite the upper second molar. Okay, don't get tricked by these things. So overall, most common tumor of parotid is pleomorphic adenoma, but most common malignant tumor is mucoepidermoid. There is a classical appearance of pleomorphic adenomas, pleomorphism. It's a salivary gland, so you will have these acini, but it will also have these other elements, myxoid elements. That's why pleomorphism. So epithelial elements, myoepithelial elements, myxoid stroma. That is why it is called as pleomorphic. How do you diagnose it? You do FNAC. It will show you some of the pleomorphic cells. Okay, and the conventional treatment is superficial parotidectomy. Please do not enucleate. And then we have the markers of the facial nerve. This everybody knows. This I have discussed enough number of times. How do you identify facial nerve in surgery? Tragal pointer above and posterior belly of digastric below. Posterior belly of digastric goes to the mastoid. इन दोनों के बीच में, somewhere in between will be my facial nerve. Okay, tragal pointer points, digastric inserts. दोनों के बीच में is going to be the facial nerve. That's how I am going to identify it. All right. So hope this class was useful, guys. Do follow me on the platform on the Unacademy Educators app, where I'll give you regular updates of my upcoming classes. If you have any doubts, you can of course always message me on Telegram. I am on the Unacademy NEET PG group. I will not share my number, but you can message me on Telegram. But most of you have my number, so don't worry. Any help you require, feel free to ask. And if you want to learn on the Plus platform, please use my referral code 10surgery. Whatever exam you are targeting, take that subscription of that duration. Alright, so hope this class was useful. This week a lot more classes coming on YouTube, which I will be posting very soon. So take care guys, have a good day and see you soon.